Hello, I'm Dr. Leonard Matheson.
I'm Dr. Kelly Deeker.
And I'm Dr. Matthew Dodson. Welcome to our introduction to forensic rehabilitation. This brief video will help you understand how we practice.
We would like to demonstrate how this is helpful to determine the loss of earning capacity of a fictional client based on a real person, Peter.
Peter provides us with an excellent opportunity to demonstrate the value that occupational therapists bring to the forensic rehabilitation of an adolescent, compared with the limited value that physicians and neuropsychologists offer. Although their information is important, it is pertinent to stages 1 and 2 in the Rancho Los Amigos model, while occupational therapists collect and interpret information over the intervening stages to support stage 8, where earning capacity is determined.
Peter is a 15-year-old boy with acquired brain injury and significant burns that he experienced in a tragic automobile accident. We'll begin our study of Peter by pointing out that vocational planning can begin at any age.
Vocational planning helps adapt the young person with a disability to his or her values, goals, and desires.
Vocational planning helps the professionals involved with a young person to choose and fashion equipment to optimize the young person's residual abilities. Without vocational planning, we leave the young person with tremendous anxiety about the future and all of the negative consequences that can accrue. Anxiety, depression, suicidality, and other self-destructive behaviors are much more likely if we don't assist young people to develop vocational plans.
This is because disability interferes with normal development. Adolescents are inherently uncomfortable with themselves. When you have a disability, the discomfort is greatly magnified. One of the concepts that's useful to consider as we look at this is core self-evaluation.
Research has consistently concluded that poor core self-evaluation leads to problems with adult development and affects a person's lifetime income. Core self-evaluation is the fundamental premise that a person has about themselves and their functioning and place in the world.
So let's take a look at Peter as a 15-year-old ninth grade student with extensive facial and upper extremity burns and an acquired brain injury that was missed in the emergency room. He was injured at age 10 and fell behind 1 year in school.
Before going further, let's point out that Peter is luckier than most kids in that he has parents and teachers actively involved as committed members of our interdisciplinary rehabilitation team. The teachers focus on stages 3 through 5, but the parents are involved throughout and are crucial in vocational planning. Peter's folks are professionals. His father is a physical therapist, and his mother is a computer network architect.
Now, there are two important issues we must face. The first is that Peter will have a differential trajectory to his earning ceiling than he would have prior to the injury. Now, the second is that he will have a lower earning ceiling in and of itself. Let's take a look at Peter's functional limitations with this thumbnail sketch. Peter has 15 functional limitations that we have rated on a scale from 1 to 4. This is based on the Functional Assessment Constructs taxonomy. 4 means that he has no functional capacity in this area, whereas 1 means that he has a slight functional limitation.
The constructs are provided by the fact, and the ratings are generated by us as we summarize Peter's records and evaluation results. So Peter's hands and arms and one leg were severely burned, resulting in these functional limitations. Do you recall that we said that the acquired brain injury was missed in the emergency department? That is not that uncommon, especially when you have catastrophic injuries like those that Peter suffered. His burns were the real focus of attention in the emergency department and for several weeks thereafter. But his parents and then his teachers noticed that something wasn't quite right. He was having cognitive problems that weren't apparent before. It was actually their attorney that recommended that they do an evaluation of Peter from a neuropsychological standpoint and also take a look at him from a pre-vocational standpoint. That's where we got involved. Combined with sophisticated brain scanning that the attorney also arranged, the neuropsych and pre-vocational evaluation found these 6 executive dysfunctions, all of which are really crucial for Peter's vocational future. And finally, due to the problems that the burns present, Peter has problems with both environmental hypersensitivity and personal presentation. His scars are unsightly, and parts of his body sunburn very easily, while other parts don't sweat, leading to problems with overheating when he is out of doors on a warm day.
Now, let's return to core self-evaluation and how it's affecting Peter. Remember that core self-evaluation determines how fully the person can use his or her resources. This hinges on the person's self-confidence. Peter has a hard time believing in himself. He's not totally disabled. He has a lot going for him, but he has a very difficult time giving himself credit. What makes this worse is that the visible disfigurement due to his burns are so difficult to get beyond. Virtually every new social encounter is a struggle for Peter.
So, how does this affect Peter in the long run? The research shows that kids with poor core self-evaluation are less capable of translating their performance in school to their earning capacity as adults. Notice that those with low core self-evaluation have an almost flat curve without regard to their success in school. People with a 2.0 grade point average make almost exactly the same as people with a 4.0 grade point average. Kids like Peter don't value themselves highly enough to have good career success. Young people who are able to develop self-confidence have huge differences in earnings.
So let's close this out by showing you what we do with our pre-vocational work capacity evaluation. We need to help Peter and his family plan for his future. We need to identify occupations that he should consider and what he will need to be successful. And finally, we need to take a look at how his success will affect his earning capacity. First, let's consider Peter's likely annual earnings. When we have two parents with established careers, all other things being equal, the simplest approach is to consider the average of their occupations as a reasonable pre-injury expectation. This isn't always the case, but it made sense with Peter.
His father is a physical therapist and his mother is a computer network architect. Here are the most recent earnings available from the United States Department of Labor for these occupational categories in the United States and in the Minneapolis-St. Paul, Minnesota area where Peter is growing up. Based on our evaluation, we identified physical therapy assistant as the optimal occupation for Peter. He has a natural interest in this area and an inclination to follow in his father's footsteps. So we laid out a program for him to transition from high school into a training program that would allow him to move at his own pace and, with accommodations, eventually achieve the occupation of physical therapy assistant. Here are the earnings in 2018 for this occupational category in the United States and Minneapolis-St. Paul area.
Another key part of the annual earnings differential is the trajectory of growth. Everyone who is successful in an occupation experiences increased earnings, but the slope of that trajectory of increase is usually not as good for people with disabilities as it is for people without disabilities. For Peter, we projected that he will enter the labor market at the 10th percentile and progress to the 25th percentile after 3 years. After another 4 years, he will hit his earnings ceiling at the median, or the 50th percentile. And here are the comparisons between the average of his parents' occupational categories and the ones that we expect Peter to attain. On this basis, we can make a year-by-year comparison of the differential between what Peter would likely have earned without his functional limitations and what he is likely to earn when he enters the labor market with those limitations. Now we can see for the first year in the labor market, that difference is $27,120. The next factor has to do with delay in labor market entry.
We already know that Peter has lost 1 year because the time out that he needed for rehab. With the cognitive functional limitations that he's experiencing, Peter is moving more slowly in school, even with appropriate accommodations and an active IEP program. The consensus is that his slower rate of matriculation can be expected to continue after he leaves high school in whatever occupational training program he pursues. We expect that he will enter the labor market at age 24. But we need to keep in mind that his parents' occupation typically requires 4 years to 7 years after high school. People going into the occupations of his parents usually enter at age 24 or 25.
The third factor to consider with loss of earning capacity has to do with what we call truncation of work-life expectancy. People with disabilities tend to be out of employment more often and for longer periods of time, and also leave the workforce earlier than people without disabilities. Based on a wide range of factors, we estimate this to be 15%. We expect that Peter will leave his career about 15% earlier than he would have without his functional limitations.
So, here's a summary of the data for Peter. We take his date of birth and injury onset, as well as anticipated retirement age and other data points to set the stage for a thumbnail sketch of our calculations. What we're about to show you is what we can provide attorneys or clients who want an estimate of the loss of earning capacity from an injury or illness. This is not normally what we would provide to the court because a forensic economist has a more sophisticated approach. However, over the years, we have found that our estimates are reasonably close to what the forensic economists eventually present and are extremely useful in developing cases and future plans for young people and others.
So, starting at age 24, we can compare the average of his parents' occupational categories with the physical therapy assistant, both at the 10th percentile, which is entry level. The differential that we mentioned earlier provides an annual loss of $27,120 for his first year in the labor market.
But recall that there is also a different trajectory that Peter will experience in his growth of earnings compared to other people without disabilities. So as Peter matures, it takes more time for him to go to the next earnings level than it would have without his functional limitations. And at the 25th percentile, the earnings differential widens even more. This continues with the trajectory lengthening so that he would have hit the median at age 29 before he got hurt, but now he gets to the median at age 31. And the median is where Peter has his lifetime earnings ceiling. After that, earnings increase at the rate of total compensation for other civilian workers in the United States.
So now let's take a look at the end of Peter's work life. It may seem strange to think about this now, but it's critical. Because of the truncation of his work life, his last 6 years have zero income offset. So instead of working to age 67, Peter will conclude his work life at only age 61. This results in a lifetime loss of earning capacity of $4,454,890. Now keep in mind this is a rough estimate. We won't actually present this to a jury, but it can help the family or an attorney get a reasonably good rough estimate as they plan the way forward.
A key part of the loss of earning capacity had to do with the executive dysfunction that Peter experiences. Because Peter's brain injury was not identified in the emergency department and not appreciated until several months later, it could have been difficult to demonstrate that it was caused by the automobile accident. We readily identified it in the evaluation and were able to quantify it and its impact on his future earning capacity. It was one of the main factors that dropped him down from being able to go to a bachelor's or master's level training program down to the AA program that we identified for him to become a physical therapy assistant. So in this case, the participation and guidance of an experienced attorney and the willingness of the attorney to make the investment to identify the dysfunction was crucial in Peter's case management and planning. And now to get the attorney's perspective on this, I'd like to introduce you to Mike B. from Charleston, West Virginia, an attorney I've had the pleasure of working with for many years, a man who's taught me a lot about the importance of rehabilitation professionals in managing cases like this.
First of all, I think health professionals need to understand that brain injury needs to be diagnosed in the first instance. What we know, even at teaching hospitals throughout the country, well over 50% of the people who come into the emergency department who have traumatic brain injury aren't diagnosed. Unfortunately, so many people don't get diagnosed, and that allows their problems to compound over time and makes it very difficult, if not impossible, for them to recover fully from the injuries. One thing that the CDC points out very clearly is that the earlier a diagnosis is made of traumatic brain injury, the better chance for a full and complete recovery. I believe that traditional ways of diagnosing traumatic brain injury aren't really always the best. For example, many years we've used neuropsychological testing. Neuropsychologists will tell you it's the gold standard for determining whether or not somebody has a traumatic brain injury. And I don't suggest that neuropsychological testing isn't helpful or isn't important. But to truly get at traumatic brain injury, its location, how it affects function, it's really important that a well-qualified doctor obtain clinical impressions. But even more importantly, I think with the advances that have been made in 3 Tesla MRI, diffuse tensor imaging, PET scanning, and other types of brain scans are now available. Certainly, those scans are as important, if not more important, than traditional neuropsychological testing. I find 2 real problems with neuropsychological testing. First of all, these tests are normed on an average population. So if you happen to be working with a client or patient who starts out, let's say, with an IQ of 125, and we're looking at norm scores, well, this person ought to be functioning pretty much across the board in the superior range. And when neuropsychological testing is performed, they are functioning in the average range. And the neuropsychologist says, gee, there isn't anything the matter with that person. Yet, in fact, as one neuropsychologist said one time when I was talking with him in describing one of my clients, the shine is off the apple. And that's what happens when somebody has a very high IQ, they sustain a brain injury, and maybe their IQ doesn't drop, but other parts of the brain are severely injured, and we need to know where those areas are. And I don't think neuropsychological testing gets to that issue as well as other kinds of tests. Neuropsychologists do a very poor job in testing executive functioning. Executive functioning is what makes us who we are. It affects our abilities to make judgments. It affects our ability to multitask. It affects our ability to work, to have relationships with people. All of those things need to be tested for. And neuropsychologists historically do a very poor job of testing for executive function. If we do brain scanning of some type, we can see from the results of that scanning that there's frontal lobe involvement, and that really helps us better understand why our clients or patients are doing what they're doing and acting the way they're acting after traumatic brain injury. We don't live in an office, well lighted, perfectly quiet, no interruptions, no disruptions, no worries, no concerns in our daily life. That doesn't happen. And that's what happens when neuropsychological testing is performed. Now, the value of doing work simulation is that you place somebody in an environment with distractions, work, noise, the types of things that we as everyday individuals encounter when we work. Then, and only then, can you really see how somebody functions and how their traumatic brain injury affects their life, particularly their work life. But even in the work simulation setting, you can see the types of problems that people are going to have at home, that they're going to have socially, that they're going to have recreationally. By doing work simulation, you are seeing how a person is going to be able to function in the real world with the deficits they are left with after traumatic brain injury.
So that's it for our brief introduction to forensic rehabilitation. If you're an occupational therapist or a physical therapist or vocational evaluator, we'd like to help you continue to develop your career. So please get in touch with us and let us know how we can help. Take care now.